Perfect. So I will start just by highlighting my organization so people understand the perspective I'm coming at this from. So I work at NASHP, a national nonprofit, nonpartisan organization that really is focused on supporting states to accomplish their goals. We truly convene a National Academy of State Health Policy Officials. They represent governor's offices, legislative offices, Medicaid, departments of public health across the board. And they are the reason why we started working on issues related to healthcare costs. In 2016, we asked our Academy members, what is keeping you up at night? And the answer was prescription drug costs. It was when Sovaldi, the cure for hepatitis C, came out, and it was unanticipated by many state officials. I'm sure there were some that knew it was coming, but a lot of state officials, this was a surprise, and a surprise to their budgets. And it has only, drug costs have only increased. Their concern about drug costs have only increased. So we did create this center. This center is focused on supporting states to protect consumers from high drug costs. We have a number of different policies that we have pulled together with state officials, helping us figure those out. And then there's also been a number of different papers related to lawsuits and other legal concerns. So just point you in the direction of that center. Here's a just quick snapshot of some of the issues that states are looking to address. On the right side here are a number of different model legislation and contract language that NASHP has created at state requests. It is everything from increasing transparency to understand drug prices, to addressing pharmacy benefit managers, which we'll talk about more in just a second. But there's also efforts to get at price, everything from wholesale drug importation to leveraging international reference rates and or helping states make the most of the new Medicare negotiated prices. And I just want to flag that we also do legislative tracking that we make public on our website so folks can take a look. And although Nevada is not in green on this screen, they have done some things, and we have captured Nevada's legislation on pharmacy benefit managers and others. But so here we are talking about drug spending in connection with consolidation and corporatization of medicine and healthcare. And by and large, it's because of the price and our increased spending per person that just keeps climbing. As you can see on these charts, there was a dip in other healthcare spending during the pandemic because of social distancing and other things. However, drug pricing continued growing unabashedly and continues to do so. So it is a top priority on states' minds. And as we go through the presentation, I'll just note while I am going to focus on PBMs or pharmacy benefit managers, there's also a lot of focus that states are turning to actual drug prices. So just to note that while pharmacy benefit managers do have an important role to play, and there is increasing concerns about their role in increasing overall costs that consumers and other purchasers are experiencing, there is also just price setting at the manufacturer level that states are also paying attention to. Here's just another look at those two graphs just to highlight what we're talking about when we're talking about prescription drug spending. And while it is not the largest proportion of spending, as you can see that green sort of foundational color, it really is the spending that is climbing actually pretty consistently and on trend a lot faster. Okay, so NASHP has been following a number of different research. Is it price? Is it increases after drugs have already launched? We see that. But I will say over the most recent years, as you can see from this research that was published in JAMA back in 2022, launch prices are starting to be the real issue, particularly for purchasers and payers. Some of the innovation that's happening in the drug space is truly remarkable. And there's a recognition that there is a cost to that and that there's price that has to go along with it. But there is also this tension of making sure that there is affordability and that people are able to actually make use of these new drugs. So I just wanted to note that it's both watching price increase after the drug has been launched and also launch prices. And then that brings us to the pharmacy supply chain. So as everybody in the audience knows, there are multiple participants in the supply chain. We are going to focus specifically on PBMs. But as you can see, wholesalers are in the middle, dispensers are sort of more at the end, providing the prescription drugs to patients and consumers directly. And then, of course, there is the consumer. There's also government participants in that they are payers, regulators, and from a state perspective, it's across the board. We often think of Medicaid, but there's also the state employee health plans, Department of Corrections, public health, and other entities. So this is a flow of products, funds, and services within the drug supply chain. This is something that actually a state official drafted during a conference as they were listening to a number of different experts on sort of start to finish where the funds and drugs sort of flow. And I'm not going to go through the whole thing. It just goes to show that the pharmacy benefit manager does play an important role, being sort of in the middle of all of this. And we've mentioned transparency throughout the conversation today. I think one of the biggest issues in prescription drug supply chain is that there's very little transparency at any given point about where prices are increasing and even what they are as patients are receiving their drugs, sort of where it started from the manufacturer setting the price all the way through. There can be a number of rebates. There's coupons, but there's other deals that take place between wholesalers, pharmacy benefit managers, health plans, and others. So this is just a quick snapshot of state legislative action to date. NASHP has been tracking this since 2017. And as you can see, all 50 states have passed some kind of legislation to address prescription drug pricing in the past 7 years. I will note that pharmacy benefit managers are clearly the sort of focus of state regulation. And as you can see, all 50 states have passed some sort of provision regulating PBMs. I will go through what those have been, but I will just sort of circle that over and over. One of the major reasons why states are focused on pharmacy benefit managers is because they can leverage their existing infrastructure with departments of insurance to help have some enforcement and have somebody within the state infrastructure that has responsibility over the regulation that gets passed. In some of these other places, states would have to establish something new or ask an existing entity to do something new. And so in part, it's because of the infrastructure that states already have that lends itself to regulating pharmacy benefit managers, but it's also because of the opaqueness within the supply chain that is really sort of begging states to pay attention to what's going on there. So what do PBMs do? They really are sort of the central hub of the payment chain for drugs. They negotiate manufacturer discounts and rebates. They receive payment from manufacturers. They create formularies. They process claims. They do drug utilization reviews. They really manage the prescription drug benefit for health plans. They are contracted by health plans to do that. As you can see, they are highly concentrated. There are 3 companies that make up 79% of the market. And this helps highlight exactly what that looks like. This is from a report that the FTC put out just this July. There is a link to the report here, and you will see that pharmacy benefit managers are also, we know that they contract with health plans, but the top 3 also are affiliated with large pharmacies. And so the concentration and vertical integration of PBMs is pretty significant. As you can see, there are the next 3 that have another sort of large-ish proportion of the market. And the fact that 6 PBMs process over 90% of the United States prescriptions in 2023, and we're talking about over 6.6 billion prescriptions, is pretty significant. So what are states doing to regulate PBMs? First, it's increasing oversight with an eye toward protecting consumers. Banning gag clauses. These are clauses that keep a pharmacist or honestly a health plan, but normally it's a pharmacist, from sharing with a consumer that there is another drug that does the same thing for less money. So there has been a ban at the federal level, but that really did start with states passing these gag clauses first. Increasingly, states are licensing and registering PBMs that are doing business in their state, very similar to how they license health plans. There has been increased interest in limiting patient cost sharing. That's being done in a number of different ways, depending on the state. There have been laws that restrict how much a patient can spend at the drug counter for a specific medication. A number of states are focused on insulin. Really, the federal government has been mirroring that with their regulation and restriction for insulin for Medicare patients. There are states that have done the same thing. And the limits range from $30 for a month's supply to even $100 for a month's supply. There's also some laws that require that if there's a manufacturer coupon available or something like that, that gets added to the patient cost sharing directly at the pharmacy counter. Transparency has been a really big push by states. Transparency to understand how much pharmacy benefit managers are paid by the health plan, or how much they are paid through their acquisition and retention of some drug rebates that they get from manufacturers. And then there is a contingency of states that are legislating to really ensure there's adequate pharmacy reimbursement. There's been quite a bit of documented and also anecdotal information from states that independent pharmacies are highlighting that they are not being treated the same in payment by PBMs as they treat their affiliated pharmacies. So there is a push by some states to establish maximum allowable cost, or MAC list requirements. Without these requirements, PBMs can actually make changes to they establish the maximum allowable cost that they have in contracts with pharmacies. And pharmacies were reporting to state officials that PBMs were changing the list price, sometimes after they had been paid by the PBM, and then the PBM was requiring retroactive clawbacks or retroactive denials, which states are also seeking to prohibit. But by establishing maximum allowable cost requirements about how often those list prices can be changed, who can make those changes, how they must be alerted to, and what guiding principles those are allowed for making those changes have been put into statute. And then another increasingly popular focus area is preventing or prohibiting spread pricing. So spread pricing is, at least in this context, really is when a health plan makes a payment, a manufacturer provides a rebate, the PBM retains some of that rebate and does not pass it on to the health plan, nor do they pass it on to the consumer. And they retain that as payment for their services rather than getting administratively paid for their services. And this was a very popular practice, and in many respects still is, but without being able to understand how much rebate we're talking about, even the health plan may not know how much their PBM is actually being paid to do the services that they're doing. So states have gone about this in different ways. One, transparency, requiring reporting by the PBM to the health plan and or to the state about how much they are getting in rebates. There's also been, and this is happening to a lesser extent, but states extending fiduciary responsibility to PBMs because they are a contractor of a health plan. So health plans having a fiduciary responsibility, and also in many respects being required to follow medical loss ratio standards that PBMs are not required to follow. Some states, Maine being one of them, has put forth a law that says the PBM has to follow the medical loss ratio that the health plan they contract with does. And so they need to be paid an administrative fee that should be considered in the 80-20 or 85-15 medical loss ratio construct that the health plan has, rather than it being considered a medical benefit and therefore being on the 80% side rather than the 20% side. And then there's also improving state contracts. So having carve outs so that rather than having, for instance, some Medicaid agencies have realized that they have, multiple different contracts because they have multiple different managed care entities, each of them having a different contract with a PBM. It could be the same PBM, but that there are multiple different contracts. Some Medicaid agencies have said, we're going to carve out prescription drug costs from our managed care, and we will have one PBM contract, and we will have disclosures to that. State employee health plans have started looking at reverse auctions as a way to procure PBMs. So this is a process by which there's a sort of public approach to the procurement. They get bids, they put out their RFP, they get bids from the PBMs, and then the state will go out and say, this is the best that we've gotten. So who can meet that or go above it, and have that be a very public experience rather than just behind the curtain. I just wanted to share this example. NASHP has recently been asked by some state officials to better understand just how much hospitals are paying for specific drugs. Because again, this is something that is really opaque and not transparent. And so we went to the hospital transparency files that are required now through federal government regulation. And we looked at one hospital that has 52 different payers and looked at one specific drug. We absolutely looked at Keytruda, and we made sure that the milligram and the dosage was absolutely the same across all the payers to understand just how much the fluctuation could be for one hospital to be purchasing a specific drug. And as you can see from this graph, it really does go anywhere from about $5,500 all the way up to like over $20,000. So the fluctuation is incredibly varied. The only rationale that we could add to why this is so all over the map, we really do think it has a lot to do with consolidation and the market power that a specific payer has with that specific hospital. I will note that this is not net of rebate. So we don't know ultimately what the rebate for this drug would be and how that would affect the payment. And again, why Keytruda, it was available. The transparency files are not the best. So we wanted to find a specific drug that we could do a comparison with. But I just share this because we know that PBMs have a very distinct role in managing the prices that are being paid by different payers. And it just goes to show just how varied all of this is. So then I just feel like as we're talking about the consolidation and as we're talking about corporatization of healthcare, understanding the 340B program and its impact on RX prices in particular with consolidation. Many of you may already know what the 340B discount program is, but just to remind you, it's an older program. It's been around for 30 years. Essentially, it mandates discounts from drug manufacturers to covered entities. Those covered entities you have to meet specific criteria. I think we typically think of the covered entities as federally qualified health centers, rural health clinics, others like that. Also, nonprofit hospitals that are receiving disproportionate share also can be qualified, so they can be quite large. And essentially what this program does is establish just minimum discounts of about 23%. But it essentially says that and I'll just note, a covered entity without an in-house pharmacy is allowed to contract to an outside pharmacy. And this was the original program, but it has grown. I will get to that in 1 second. But here's sort of what it looks like from a financial perspective. So you've got a hospital that is a 340B entity. Manufacturers provide the 340B entity with a discount. The 340B hospital provides those medications to patients, and then an insurer reimburses the hospital at the fully negotiated rate. So what that means is, say you've got a insurer that reimburses a hospital $100 for X drug. The 340B purchase price was actually, $60. So the hospital paid $60, got $100, and then there's a copay from the patient of $10. The 340B entity now has, and it can profit by $50. This is done because, again, back in 1992, there wasn't as much health insurance coverage as there is now. And this was meant to offset and provide health services to individuals that may not have insurers. So it's leveraging a discount that drug manufacturers were providing to give some level of financial assistance to certain providers so that they could then use that money to serve other individuals. There have been changes to the program. The changes to the program have essentially broadened how 340B entities are defined. So there are more 340B entities. And then there was also an expansion so that a 340B entity can contract with multiple pharmacists, multiple pharmacies. So this has resulted in the number of covered entities being about 50,000 or more. This was back in 2020, so we believe it has grown. And the prior to 2004, hospitals accounted for about 10% and now account for over 60%. That's important in the consideration of consolidation. So as hospitals are now considered 340B entities that get these deep discounts on prescription drug prices, but then benefit from the higher price that insurers pay, it has become an important revenue stream. The other piece of this is now contract pharmacies include CVS, Walgreens. So I'm just sharing this because it is broader than just the inpatient hospital administration of drugs. As hospitals or others acquire or merge with provider groups now can carry that 340B entity status. It really has to do with the prescriber rather than the actual drug or the insurer. So I like to explain, I personally go to a provider that's part of a larger system. I know that whenever I am prescribed a 340B drug, then that benefits my the health system that owns my provider. So a lot of folks think it is just for the very poor people, or that it's based off of only if you've gotten a drug in a hospital, and it really is broader than that. And so it is incentivizing, and this is complicated. The slides are available after this, so I put this in here not to go over right now, but just so that people have this. But just so you see just the amount of purchases at a discounted price we're talking about. So in 2021, the value of 340B purchases at list price was, $93 billion. And then the discounted prices were $44 billion. And so this has become an important revenue source for providers, which is incentivizing, and I believe we've got this here, which is incentivizing hospitals and other entities to affiliate with, merge with other 340B entities, because not only do they benefit from having that market power of just being a larger provider, but now they also have the benefit of increased number of 340B prescriptions, which will bring in additional revenue. And I will note that by and large, when it comes to pharmacy benefit managers in 340B, manufacturers only have to give one rebate. So if they're selling a drug at the 340B rate, they don't have to have an additional rebate that they give to a pharmacy benefit manager or others. So there has been some concern or some observation that there could be pharmacy benefit managers that were steering some of their patients or benefits towards non-340B entities. And so there has been a number of different pieces of legislation that have been passed that actually prevent PBMs from discriminating against 340B entities. And Nevada has passed one of those. So I'll just close with this picture to highlight just the sort of dramatic cost that 340B does end up realizing for providers, but it can cause some challenges for overall drug pricing efforts to reduce prices when there's an incentive to keep them higher. And this also sort of mirrors the incentive for pharmacy benefit managers to steer formularies and others to higher drugs, because even aside from 340B, their potential rebate could be higher on higher cost drugs. And so all just to say, there's two sort of different mechanisms within the drug space that are increasing, and we have to watch, related to consolidation. Pharmacy benefit managers and their overarching power and their responsibility to set formularies and then just manage rebates and negotiate those is one. And then the 340B drug program and what that's doing to incentivize some providers to increase their footprint to bring in more of those rebates themselves. I'll just note that NASHP does have a couple of model laws related to pharmacy benefit managers. You can find them at our center, which is noted here. And then you can also see we have a number of different resources related to PBMs. So you can see the direction that states are going in and how and why they're trying to regulate some of the PBM practices. So with that, I will stop screen sharing.
Thank you, Maureen. I know this is that prescription drugs are getting a lot of attention in the upcoming election. We had the insulin prices controlled, and that's been touted as a major political issue. Are there how do legislators determine which drugs should be marked or targeted for specific price controls?
It's a great question. I think insulin was pretty easy because, one, as we know, it is a life-saving drug that people depend on. Two, insulin was, and I used to remember the year right off the top of my head, but it's been around for a really, really long time. And the story has been told that the manufacturer of that made sure that that could be available to anyone. And the fact that insulin prices were increasing just didn't make any sense to anybody. And the fact that the cost to manufacture insulin is low, it really was a no-brainer for legislatures to say, like, we need this available. It's not costing you a lot. We're going to go ahead and set some cost sharing restrictions for consumers. I think if there are other drugs in a similar place, I know a number of legislators have looked at the EpiPen for epinephrine and things of that nature. But I will say it does get hard because some of the most utilized drugs are high priced drugs that have patents, and that makes it harder to just makes it harder. But insulin also having a generic is an easy place to go.
Okay, I want to remind our participants that you can ask questions in the question and answer window. One of our participants reported today that the FTC has filed an antitrust consumer protection lawsuit against the 3 largest PBMs. Should states or federal governments do more to legislate these practices, the PBMs in general, not just the top 3, but all of them? Maybe that's a loaded question.
I mean, I think they are trying. As you can see, every state has passed something. And I will say in sort of watching all of this unfold from the position that NASHP's in, States started with focusing on, like, there was a rash of bills when we first started our center on transparency. States really wanted to understand what's going on, help evidence lead them in the direction to legislate and build policy. And then as they started understanding the supply chain, it was really a number of them immediately focused on pharmacy benefit managers and really were like, we have to really address, we regulate health plans, we should be regulating the contractor of those health plans in making sure that there are fair practices going on for consumers. There has been litigation against states in trying to regulate PBMs. There has been litigation against them in addressing high drug prices and other respects. So I don't know that it's lack of want or will to regulate these entities. I think it's really trying to get a grasp on what the problem is. There was at first transparency for PBMs, then there was an understanding that they were being paid through spread pricing, and so nobody knows how much that is. So then there was regulation related to spread pricing. Now there is a push more and more for requiring fiduciary responsibility. So increasingly states are getting more aggressive in their regulation, but I do think there's a number of states that are looking to the federal government to make some federal and I know that Congress has a bill that has been moving and being negotiated related to PBM regulation. And so I think there's a will. I do think it's hard to do.
Another question asks, as public payers like Medicaid move to MCOs, will they lose authority over prescription drug pricing? Essentially, will legislatures lose the ability to impact this pricing?
So because prescription drug, everything in healthcare is complicated, of course, but for Medicaid, you also have the Medicaid drug rebate program. And the Medicaid drug rebate program provides Medicaid with a deeper discount than what anybody else gets. And so the Medicaid market is a very different drug market than the rest of the sort of commercial space. But I will say there have been a couple of states, probably more than a couple, that have broken out from their managed care contracts, the prescription drug benefit. And they have done that so that they have better insights over what that contract with a PBM looks like, but then they can also be the one that is responsible and in charge of managing that contract rather than yielding that responsibility to an MCO. California has done it, New York has done it, West Virginia has done it, Ohio has done it. So there's a number of states that are trying to, even using managed care, to support that coordination and all of the benefits of that for the medical part of their Medicaid benefit. But then the state is there's more and more states taking their prescription drug Medicaid benefit in-house, not necessarily taking it away from a PBM, but managing that PBM more directly.
What about on the issue of brand name drugs? There have been some brand name drugs that have been on the market for much longer than would be required under turning these drugs over into generic, to the generic market. Why are they able to do this? And has NASHP looked at this, or, has this been a policy point? I mean, some of these drugs are very high priced, and comparative drugs might be, a fraction of the cost. What reasoning are they do they get by with the continuing to maintain these drugs as brand name drugs and full cost drugs?
Yeah, so I am not a patent attorney and don't pretend to be, but I will say it is federal patent law that oversees that, and states have limited ability to address that. I will also say we know that that manufacturers may like find there is a drug, I won't name it, there is a drug that is sort of known for this, like they identify a new way that it resolves like a new medical issue, and then they get like they renew their patent for that medical issue rather than the first one that they got approved and had the patent for that. So that there's a way to game the patent law in order to retain your brand name patent status. And we know that that would take a federal law to fix that problem.
Okay. All right. Well, I want to remind our audience that there is a short evaluation in the pop-up for the program, and if you have any more questions, we have a little bit more time. But I did want to ask a question about the 304, I mean the 340B program.
340B.
And you talked about that it's turned into a cost benefit for providers out there specifically, and how it's affected hospitals pricing. So it's become a resource center for hospitals rather than a cost center. Prescription drugs have prescription drugs have always been a resource center for hospitals. But was that an unintended consequence? And is that something that the law really wants to maintain?
So there's been I can't speak to the intention. I can say that because of how big the program has become, and because its reach is so far, and essentially it's being paid for by health insurers, and you could argue manufacturers. Employers are starting to question the value of the 340B program and whether it has moved beyond its original intent. And so I know there are a number of conversations happening. It is a federal program, so states can't really get in there and legislate around it. But there has been increased interest at the federal level in the program to understand, are 340B entities truly taking the money that they have as a result of the 340B program and investing it back in their community? And are they taking that, and are they making sure that perhaps some of those dollars could erase somebody's medical debt or what have you? There's little evidence to date that that's happening, but then there's also this and maybe it is, and we just don't see it. But there's lack of transparency into how much money we're talking about, and lack of transparency into how those funds are being spent by the provider entities that are receiving them. And I do think, if nothing else, there will be a demand for more transparency. There are states that have asked NASHP to pull together a 340B transparency legislation. We have not yet to date. But there are 2 states that have passed such legislation. So Minnesota has passed 340B transparency legislation, so has Maine. And so both of those states are trying to understand what drugs are bringing in the highest 340B revenue, and trying to understand what that amounts to, because there's also middlemen within the 340B program. And so where is the money going? To whom? And then how is it being used for the community? It's very new, and these states haven't reported what they're learning yet. But we are keeping an eye on that, and we'll see sort of what comes from it.